Steve Bowers welcoming you to Dialogue here at E+ TV6 and a conversation with Dr. Dave Roberts, Chief Medical Officer with West Tennessee Healthcare in Jackson-Madison County General Hospital. It's a real honor to have you here. Appreciate the opportunity to talk with you. Got a couple things we want to talk about. We're going to begin with antibiotic stewardship, and I have no idea what that is, and so we're here to find out. So what is this?
We'll start out with a good definition of antibiotic stewardship. Basically, antibiotics, like many other things, is a limited resource that's used heavily in healthcare, both in the outpatient and the inpatient treatment of patients who have bacterial infections.
All right.
Over the last several years, we've had an explosion of resistance to the antibiotics that are widely used across the country.
Okay.
And as a result, many of these antibiotics are becoming sort of endangered species with regards to their ability to effectively eradicate infections in patients.
So it's not the supply of them, it's the fact that they're not effective anymore.
Well, they're becoming less effective as more and more resistant bacteria develop. Bacteria are they're very smart organisms, and they learn to go around our antibiotics after they're used widely and continue to cause issues in patients and people. Part of that is basically because we have not done a good job in the healthcare profession of just using antibiotics where they need to be and not using them where they are not effective. And there are a lot of things, a lot of circumstances where antibiotics are used where they are not doing the patient any good and may actually cause harm and create resistance, which is now a national issue.
So anytime I go and have a cold or whatever that is, you know, they give me a thing of antibiotics, right? So we're doing too much of this?
Absolutely.
Okay.
I think that the recent literature shows that somewhere between 30 and on the outpatient side, as much as 50% of the antibiotic prescriptions that are prescribed don't have good indications for those antibiotics to be
used.
Yes.
Okay. So it's become too general.
It's become very general.
Okay. So.
And
take 2 aspirin, call me in the morning. So it's become antibiotics.
Yeah. And when sometimes take 2 aspirin, call me in the morning might be a better treatment regimen in some cases.
So what happened to create that then?
Well, I think over the years we became kind of complacent with the development of new antibiotics constantly by the pharmaceutical companies, and so we would just develop a new antibiotic category or family that would take care of gram-negatives or gram-positives or all these different bacteria. For several years we were good at that, but at this point we have now come up against sort of resistance that we've never seen before.
And that's because we were overprescribing them.
That is a lot of
it. The bacteria goes.
Yes.
They're designed to survive too.
It is, but it also is because the bacteria have accelerated their ability genetically to find ways to resist the antibiotics so that it doesn't.
So what are we seeing then as the effects of that? What's happening that you're?
Well, this has become such a huge issue, Steve, that in 2014, President Obama signed an executive order requiring all healthcare systems and hospitals across the nation to develop an antibiotic stewardship program. And that means just what it says, that we are to look carefully and measure our use of antibiotics and find ways to decrease that use of the antibiotics. There was actually a goal set, and that goal was 20% reduction in the use of antibiotics and the restriction of certain very powerful antibiotics, which are some of the last ones we have to treat certain kinds of very lethal infections for those specific cases. And so that was an order signed in place, and we now have to report our use of antibiotics to the CDC in Atlanta, and it's being tracked nationally and locally.
I can do that through a hospital. Can I do that through medical clinics and other things? How do you reach into that network?
You're asking a very insightful question, and that is where I think there is a real opportunity. We do not have a formal program on the outpatient side, and part of my reason for wanting to discuss this with you and with your viewers is to let them know what they can do, particularly in the outpatient side, because 70% of healthcare is done in the outpatient clinics. It's not done in the hospital
anymore.
Yes. And 70% of the antibiotic prescriptions occur in clinics. So that's really the message that I want to give to you, to the viewers.
What control do I have as a patient into that? Do I say, well, is there something else I can do? I mean, is it up to me, or is it up to the medical professional to go, okay, we need to look at this?
Yeah, I think it's both. I think that we, the medical profession, need to hold ourselves accountable for doing a better job of stewarding anaesthesia. And by the way, I mean, the reality is we're the ones who write the prescriptions.
Right.
Yeah, and tell the patients what we think.
Because when you do that, and my inclination is to, okay, well, great.
I think it is. I think
It'll
the
make me feel
inclination, and
better.
for some patients, the inclination is to say, well, this is what the doctors give me, so I shouldn't, just.
Okay.
Well, I think what we need is a partnership between our patients and the physician to make a decision about whether or not the risk and benefits of taking the antibiotic are there, and whether or not there are clear indications.
Okay.
So there are several things that patients can and should do. And if I'm writing you a prescription and you've got a sinusitis, and you say, Dr. Roberts, do I really need this antibiotic?
Okay.
And even though it's not an exact science, there are a lot of signs and symptoms and things about your condition that can help me decide, this is unlikely to benefit from antibiotics, and so let's treat you symptomatically and stay in contact with me for the next 3, 5, 7 days. And if things change, then we will proceed with the next step, which may be the addition of antibiotics to your treatment.
So it's still a catch-all because is it viral or is it bacterial or
That's
whatever,
right.
I mean, and I don't know. I feel badly,
Right.
whatever crud and whatever. I'm going to use real scientific terms. Doctor, I've got the crud. Okay. And so we need more precision than that.
Yes. Well, we do. Again, it's not an exact science.
Right.
But I can tell you based on how long you've had those symptoms, what those symptoms are.
Okay.
Whether or not you have.
Well, we're going to spend time together.
That's right. Well, you're getting. I think two things.
Okay.
The culture has been to expect from the physician that I will get an antibiotic prescription.
Right. Yeah.
And physicians would like to meet your expectations.
Okay.
We want to give you good care. But it actually takes longer for me to talk with you and say, Steve, I think more than likely your sinusitis is viral, or that your cough from your cold is a post-inflammatory cough, and it's going to take another 3, 5, 7, or even 10 days for this to go away. These antibiotics probably will not make any difference based on what your symptoms are at this time.
What would you give me then? Because I'm going to expect you to give me something, right?
Well, you can use antihistamines, decongestants.
Okay. So there are other,
mucolytic agents to help you.
To help with the symptoms of this, right?
Also non-pharmacologic treatments, humidification, some things like that, rest, additional rest.
Oh yeah, well now you've gone to meddling.
Fluids, and grandma used to say, soup and bed rest. It's still a pretty
good deal.
If people will give themselves additional time to clear the infection.
All right.
So those are simple, straightforward things. But I think the question should be, am I going to benefit from this antibiotic? Would you recommend that I wait? What exactly are we treating? Okay. Are we treating streptococcal pharyngitis?
Right,
are we treating bacterial bronchitis, or is this a viral, more than likely viral? And at how long? De-escalation of these antibiotics, not take them for any longer than I have to.
Because my experience, Dr. Roberts, has been, I'm late and whatever. We have 5 minutes, and and they say sometimes I say, well, it could be bacterial, could be it could be viral, could be take this.
Right.
See you.
Right.
If you don't get the feeling better, come back and see me.
Yeah.
Right. And that's kind of the extent of our, and so that's dangerous because it's having then significant effects on the things that are attacking us.
That's right.
They're getting better at this.
We clearly know.
We've unleashed the monster out there.
We clearly know, for instance, that children who've been on lots of antibiotics throughout their lives are at significant risk to develop resistance to the pneumococcal streptococcus, which can kill you if it gets in your lungs or in your bloodstream. Because the antibiotics that we all have in our bodies, the bacteria that we all have in our bodies, over the time have developed resistance to these drugs, and then when you truly need them, they're not effective. And we're beginning to see more and more of this across the nation.
Sounds as if the genie's out of the bottle. We're going to see what the effect of that is going to be.
Yeah.
We'll talk to Dr. Dave Roberts. We'll continue this conversation. This is Dialogue at E+ TV6. Welcome back to Dialogue at E+ TV6, a conversation with Dr. Dave Roberts, who's the Chief Medical Officer of West Tennessee Healthcare, Jackson-Madison County General Hospital. Talking about the stewardship of antibiotics. We take them pretty readily, and if you're just joining this conversation, I hope you'll catch us on replay, because the foundation is that we have overused these, and now the things that attack us are getting better they're getting more resistant to our antibiotics. Yes. And then we are more susceptible. So this generationally could have significant influence on what happens to us. So the things out there that used to wouldn't kill us, that could now, because it's stronger than we are. Okay.
That's exactly right. And we're actually...
Ag community goes through this with insecticides and pesticides and everything else.
They do.
Nature, I guess, is it's designed for this, right? It adapts.
It adapts very, very quickly, very rapidly.
Okay. So what do you see then as the implication of this for public health?
Well, I think that our communities have to help us with this, because the culture has been to receive and expect antibiotics without asking many questions. But the questions I referred to earlier when we were discussing are part of it. The other is to understand the downside of taking antibiotics. That we now are having issues, for instance, with an infection called Clostridium difficile, and I won't go into too much of the bacteriology on that, but that is an organism that grows in your gut and as a result of broad-spectrum antibiotics.
Okay.
And that organism, when it overgrows, because it doesn't have any competition from the other microbiology that is normal in your body, overgrows and becomes a horrendous infection, causing diarrhea, can injure the colon and your GI tract, and can end you up in the hospital very, very sick. And then we have to figure out a way to treat the increasing number of patients who have that infection, which is a side effect, if you will, of having taken a lot of antibiotics. Okay. So that those are some of the downsides.
Okay.
The other things I'd like to mention for viewers to understand and know about is, if you are taking other medications for your blood pressure, for your heart, for your lungs, and so on and so forth, there can be drug interactions.
Okay.
Or if you're a
mother, antibiotics complicate that?
They can make those either not work, or can actually make the levels of other things go too high and injure you. So there's all those.
So antibiotics need to be carefully used.
That's right. That's right. They need to be thoughtfully used. Now, I don't want to scare folks to death with this, but I think that we're going to have to use a more targeted approach to both the prescription, and not use as many what we call broad-spectrum antibiotics that kill a whole bunch of organisms, and try to treat specifically what you have as best we can figure it out. And we have better tools now to figure that out than we used to, particularly on the inpatient side. We have some specialized laboratory testing that we can do, which is helpful. The other is treating patients for shorter courses and avoiding antibiotics altogether when possible. And our patients can help us with a culture, I don't mean a biological culture, but a culture in our community of asking the question and only taking them
if we need it. Okay, so there's some resistance there. Pharmaceutical companies are not going to like you particularly, I wouldn't think.
Well, I think that the pharmaceutical companies have
they begin to recognize it.
Recognize this, because they're the ones who are now trying to develop antibiotics that will work against these horribly resistant, and they're not having much success at doing so. So their incentive, I think, should be both that they want to do the right thing for people, and they do a lot of great things, but they also want the antibiotics that they have to work so that we can use them when they're needed.
Antibiotics, stewardship of antibiotics, rather than just consuming them or expecting them or prescribing them willy-nilly. Then
that's the message.
Is a big thing, because of the long-term effects of that. There is some interesting stuff about agriculture in the same sense that, we got all this cotton seed that's resistant to everything, and all of a sudden we get used to it, and they say one of these days nature's going to wake up and it's going to end around Monsanto. Right. And then here we go again.
Right. And the agriculture area is another area where a lot of antibiotics are used. In agriculture.
That's right. In agriculture. That's right.
For the food that we consume.
That's right.
And there's a lot of emphasis to try to decrease that as well.
Well, not to overly develop concerns out there, we got one more we want to talk about, and that is opioids, and which you describe now as an epidemic.
Yes. We began the use of opioids, it began increasing the use of opioids to legitimately try to help patients control pain 10 or 15 years ago. Since then, we've seen a quadrupling of the number of opioid prescriptions that are written, and we now have large numbers of patients who are prescribed opioids for a wide variety of reasons. The group of patients that are particularly at risk are those who are on chronic opioid use for chronic pain.
Okay.
And this has become a huge epidemic across the country and is particularly acute or a major issue in the state of Tennessee. So much so that last year the state of Tennessee passed a law requiring all opioid overdoses that come into hospitals to be reported to the state health department.
Okay.
And so they now developed basically a registry so that we can keep up with this. The reason for this, Steve, is that those patients who are on chronic opioid therapy of all varieties are at risk for many things, one of which is death from opioid overdose that is unintended.
Okay.
And we've seen a large increase in the number of people across the nation, and about 1,200 or 1,400 people in the state of Tennessee last year who lost their lives as a result of an opioid overdose.
Okay. One other thing that I had detected, because I had some people that I know, and well, what happened? Heroin overdose. And it's like, well, when did they get on heroin?
Yes.
And it was like, well, it started with, you know, toothache or whatever, right? And it's like, you got to be kidding me.
That's exactly right.
Because when I see heroin, I go back to the 60s and streets and right needles and all this stuff. So not people that you know, you know, as adults or whatever that is happening to.
Yeah, no, a lot of these people are our friends, our families, our coworkers, people who are just like me and you, good folks, who end up addicted to opioid. And what's really frightening to me as a physician, Steve, is to understand how quickly one can become addicted to opioids.
Okay.
And many of them are from prescriptions that are written with the best of intention to relieve pain for acute things, a fractured arm or whatever.
Okay. Right. So the common opioids then would be what?
Well,
that we get if we go in, like say we broke an arm, we get toothaches or whatever,
sure.
you know, some kind of infection. Take your antibiotics,
Right.
and then take this for pain. Right. So I'm double loading. I'm hitting both of these at once. Right.
Right.
Okay.
Well,
so what are they?
But
it's hydrocodone, right?
yes, they're codeine, hydrocodone, oxycodone.
Okay.
A new one that morphine, and then there are many forms of morphine, Dilaudid, and fentanyl. And fentanyl is the new street drug that is killing people across the country. Fentanyl is the most powerful. It's a synthetic opioid. By that it means it is made by the pharmaceutical company. Morphine is a more naturally occurring.
Made for what reason then? For intense pain?
Yes, for intense pain, for end-of-life care pain, for cancer pain.
All right.
That patients require this for relief of their pain. And let me say, I want those drugs available to relieve people's pain who have pain like that. But for chronic pain, or for patients who have an acute self-limited process that they need pain medicine for a few days and they're going to get over it, their fracture is going to heal and they're going to move on, are the people who need to be extremely careful about the use of these medications for prolonged periods of time. And there are signs that you might be at risk for developing it.
Oh, is that all right? Okay.
Yes.
All right.
And those are if you require increasing dosages to relieve your pain is one.
Then,
if you have a previous history of addiction to anything, alcohol, drugs, even compulsive cigarette smoking, could put you at risk for the development of this. And then the amount of drug that you're taking. And we know what the levels are. They're in something called, we use morphine milligram equivalents, which I won't get into, but just a way for us to measure all of the drugs in that family.
Okay. Opioid is an epidemic, says Dr. Dave Roberts. We'll continue this conversation. This is Dialogue at E+TV6. Welcome back to Dialogue at E+TV6. If you're just joining us, we're talking to Dr. Dave Roberts. He's the Chief Medical Officer at West Tennessee Healthcare, Jackson Madison County General Hospital. had a discussion about two things, the stewardship of antibiotics and why it's important, and that's because as we have used more and more of them, the things that are resistant to that are finding ways to enter around, so we're going to need stronger ones, and we may need to change our medical protocols to help address this. And then the epidemic in opioid pain relievers that has now, if you talk to any drug treatment center, alcohol treatment center, whatever, it's an increasing load now on treatment centers is opioid, which is coming through prescription. I know that I've gone and you know, and had dental work done or whatever, and then, you know, and you get a thing,
yes,
right? And it's more than, I mean, I don't know how you, and what you're saying is we need to be much more precise in all of this.
That's right.
Right? Instead of giving me a half bottle, and I've still got a few lying around the house, I'm sure, right? I hadn't thought about it until we had this conversation, but, okay. So we've been way too liberal in the way we're using this,
I think
or prescribing and using.
I think we're all have the same sort of thing. You go to the dentist and have your root canal, and
right.
Yeah,
like I said, I get antibiotics, and I get
you get antibiotics, and you get some Percocet, or you get some hydrocodone,
right.
and you hopefully you just take one or two, and you're done.
The assumption is when it's prescribed to me that you're going to be reasoned in using this, and if you're not hurting, you don't take this.
Right.
What happens then?
I'll tell you what happens. We have a huge reservoir out there in our medicine cabinets of opioids.
Okay. I'm sure I do. I hadn't thought about
that young people, if you have children, if you have teenagers, if you have other people who've had a history of addiction of any kind,
they're looking for this.
They're looking for this. And our medicine cabinets are a reservoir across the nation for this. And
then it goes from where then? I mean, this extremely strong substance you're talking about that's there for cancer patients, whatever, is in the marketplace somehow or another. It's coming from where?
Well,
how do we get to it?
Many of them are legitimately written prescriptions with the best of intentions. But there has been a significant amount of diversion of these drugs, like the ones you just mentioned that end up on the street, and then patients who have become addicted, who can no longer get legitimate prescriptions, but there are lots of ways to get legitimate prescriptions.
Is that where the heroin then eventually comes in?
That's where it comes. And the opioids are a crosswalk, if you will, from the opioid addiction, and it leads people into heroin and illicit use of fentanyl. And both of those are very deadly and dangerous.
So addressing this, because this is multifaceted. At first, medical communities say, okay, we need some flags up here about antibiotics and about these opioids that we need to change our protocols.
Right.
That's one start, right? I, as a consumer then, also need to be, okay, but is it appropriate for me to tell you, well, I don't need a half bottle or a, I mean, I'm going to be,
I think it is.
As a patient, I mean, you know, of course, I was raised in a time when the doctors were very few and they knew everything, okay, because they treated everybody in your family. They were your only outlet, right? Okay, so there's a trust factor there. I would be uncomfortable, Dr. Roberts, coming in and say, well, Steve, take this. And I say, well, do I need this, or do I need this many, or, right?
Yeah, but I do think it's okay for you to say, you know, people normally know that, and I ask them, do you think that, I think we can just use Tylenol or non-steroidal anti-inflammatory drugs and heat and cold and so on and so forth, and you'll do okay. Here's 3 of these. If you get in pain and you need them, they're here for you to take. If you have more pain than that, maybe we ought to have a discussion. And then I think the other piece of it is certain people are genetic setups for addiction. And these morphine opioid drugs stimulate something called a mu receptor in the central nervous system.
Some people take a drink and it's just
they're hooked. It's a very similar sort of thing. And the other thing I think that's important, Steve, for people to understand is that these are great drugs, and we do not want to withhold them when patients have pain that we need to treat. But they are as addictive as heroin. They're as addictive as the street drugs.
See, we don't sense that, right? Because it's prescribed.
But but the prescription, I think, gives people a false sense of security that it's okay for me to take this. And sometimes that is true to a certain extent. I've
been astounded at how much, I tell this story. I was at a funeral home years ago, small town here. And, you know, when you stayed, family stayed all night, all this stuff, okay? So family. One of the ladies said, oh, I came over here and left my nerve pills at home. And all the little ladies in this And I'm talking about folks that wouldn't drink a
Right.
beer or anything, started popping their purse, said, well, honey, you can have one of mine. And I said, well, when did this happen to us? It happened somewhere, because these country people, right? They weren't raised around this stuff. And I asked mental health people, I said, when did all this start happening? So you're saying like within the last 2 decades, these changes have come, and they're going to have, they're having adverse effects on us.
They are, absolutely.
And are going to be a long-term threat to us if we don't change our protocols now.
That's right. And the community has to help us with this, Stephen. The reason that I'm talking with you here is so people will understand. I hope they don't think that we want to treat people compassionately and well. No physician wants anything different. But we have learned over the years, for instance, the prescribing of opioid drugs has to be done, again, more targeted and more specifically. I'll tell you the results.
Well, it would help, I guess, when they hand this to you, say, look, this is as addictive as heroin.
That's right.
You be careful of this.
That's right.
I mean, in that sense, right, that, okay, this is here if you need this, if you don't.
Yeah. And the other thing, that patients who are on these drugs long-term, they don't do as well. If you have a heart attack, if you have a knee replacement surgery, if you get sick, anything that occurs like that, patients just don't do well. And if you look at patients who have been on opioids for a long period of time, legitimately prescribed in many cases, 1 out of 32 of those patients are dead within 2.5 years. We've never used, in my career that I know of, a category of drugs that is more lethal potentially for patients than this category of drugs.
Okay. What do you see then as, what goes first in changing this?
Well, the state of Tennessee and Tennessee Department of Health has been on this for several years because they've seen a rise in the deaths in Tennesseans. So there is a lot more accountability being required of prescribers. And I told you about the registry where we can now track patients who may have an addictive pattern to try to intervene before they get to the point that they have an overdose or a lethal event. You've heard talk about the use of naloxone, which reverses the effect of this for patients who do get into trouble. We've also begun to track, and we have seen a decrease in the morphine milliequivalents that have been prescribed across the state by about 22% since we started tracking this and feeding that information back to physicians like me who have license to prescribe. And so they're making us more aware and holding us more accountable for it. The other piece of it is doing what we're doing now is a huge educational opportunity.
It has surprised me. I'm 67. I'm on one medication for cholesterol. I think
is this where I'm supposed to say that you look a lot younger?
Yeah, well, but around contemporaries, some of my contemporaries have Ziploc bags of stuff that they take.
Right.
I don't know for what all. And I'm thinking, well, that can't be good, right? Everything's going to have a side effect or counteract something else. That is just part of our. I expect you to be able to make me well. If I have a heart attack, I expect you to give me a new one, right? And so rather than losing the weight and doing the things to prevent it, and so it's become a dangerous thing for us all.
It has. I want to emphasize, a lot of patients have to be on a lot of medications. Their blood pressure, their diabetes, their cholesterol levels, so on and so forth. So I don't mean to give a negative about the fact that we do great things for patients, but these are two areas where our patients and our community can really help us.
Stewardship of antibiotics, and the fact that opioids are an epidemic in this country. Appreciate this time.
Thank you so much.
Very much. Appreciate this opportunity to talk to you.
Appreciate
Dr. Dave Roberts, appreciate the time with you. Appreciate you being with us. You stay with us at ePlus TV 6. This is the place where the dialogue continues.